Hello everyone. So I'm going to speak about fever of unknown origin. So it is actually defined by a medical condition that requires three criteria, which are the first one is an illness of 3 weeks. The second one, it should be fever of more than 38.3 Celsius on several occasions, and the patient should have been in the hospital at least for 3 days, and no diagnosis was a specific diagnosis was made to show the main or the real cause behind this fever of unknown origin. Also, the causes that may lead to fever of unknown origins, they are divided into four major categories, where it starts first with the infections, neoplasms as a second one, autoimmune disorders, and miscellaneous causes. Infections, it actually constitutes 40% of the fever of unknown origin causes, and it starts with abscesses where, for example, we can see especially the abdominal abscesses where they can stay for a long time inside the patient and without any symptoms. Also, we can see osteomyelitis in the air sinuses and also in the mandible and so on. We can also see subacute bacterial endocarditis, where we have to make a specific examinations and specific diagnosis to know that this is the main cause of fever of unknown origin. Also, biliary system infections. For example, sometimes the patient can even have cholangitis or any kind of biliary system infection, but without showing any kind of symptoms such as like upper right quadrant pain or tenderness. Also, regarding the UTI, which is the urinary tract infections, patient can also have UTI, but even not showing any symptoms such as dysuria and pain during urination and so on. Also, we have tuberculosis that may cause this kind of fever of unknown origin, especially the miliary tuberculosis mostly occur in HIV patients or in immunocompromised or patients depends on are being on the corticosteroid treatment. And also we have, for example, sporococcal infections. Also, we have rickettsial infections that cause brucellosis, chlamydia psittaci, Epstein-Barr virus, cytomegalovirus, especially in elderly, and also we can see fungal infections and parasites and so on. So the second major category is neoplastic, which constitutes 25% of the fever of unknown origin. Especially we can see here the lymphomas such as Hodgkin, especially Hodgkin and non-Hodgkin lymphoma. Then that can lead to this leads to this fever of unknown origin. Also, we can see patients who suffer of leukemia, and also patients who suffer of hypernephroma, and also patients with primary hepatocellular carcinoma, and also atrial myxoma. Regarding the autoimmune diseases, so they can constitute from 10 to 20% of all the diseases that cause fever of unknown origin, where we can see, for example, the first one, which is the most common, systemic lupus erythematosus, where we can see all of these symptoms are shown, and one of them is fever, of course. And here we can see the patient, especially it occurs in younger patients. The patient can show muscular rash, arthralgia, sore throat, hyperthermia, fever, peripheral leukocytosis, elevated serum ferritin, and severe elevated ESR or erythrocyte sedimentation rate. Also, we can see hypersensitivity, angiitis can also lead to this fever of unknown origin. Polymyalgia rheumatica, which occurs mostly in elderly patients, where the patient can show also, in addition to fever, muscle weakness and elevated ESR. Also, the patient can show temporal arthritis, concomitantly presence with temporal headaches and visual complaints. Also, we can see in polyarthritis nodosa and also mixed connective tissue diseases. And also we can see subacute thyroiditis, where the thyroid is tender and serum antithyroid antibodies are elevated in the blood. And the last one we have in autoimmune disease is Kikwich disease, which is mostly occurs in young Asian females, and these young females can show generalized lymphadenopathy and a prolonged fever also. The other one, it is miscellaneous diseases, which can constitute to 10% of the causes that lead to a fever of unknown origin. So it is due to, for example, drug, as in the first place, such as quinidine sulfate, procainamide, sulfonamides, and penicillins. Also, we can see it in infectious fever, which mostly occurs in females. This infectious fever actually occurs in females who have actually medical background. they are not that healthy, and what they do, they inject themselves with stool or saliva, and they cause polymicrobial bacteremia and later will cause fever. And also we can see it in familial Mediterranean fever, where we can, which is associated actually with recurrent serositis, such as, for example, inflammation of the pericardium of the and so on, or peritoneum and so on. And then also we can see pulmonary emboli, maybe after like deep vein thrombosis or DVT, can also lead to a fever of unknown origin. So we have to make a lot of examinations and so on. So the criteria for fever of unknown origin, first we have to recommend for the patient to measure both the 6 a.m. and the 6 p.m. temperature, and an electronic thermometer always should be recommended to exclude any other causes of fever. And also we have to indicate the specific pattern of fever, because every disease has a specific type of fever. So for example, miliary tuberculosis type of fever, it differentiates of course from the typhoid fever or the periarthritis or polyarthritis nodosa. So the diagnosis of the fever of unknown origin. First, we have to look at the history. First, we have to know if the patient suffers of tuberculosis, or he has some family members who are sick, or the patient was exposed to animals, or being in contact with animals, or the home environment. And also depends on the occupation or the professional disease, and also travel exposure, and a list of all medications, and etc. And also a physical examination is very necessary and it must be performed. For example, we can do a skin examination, such as we have to look for embolic presence of emboli or vasculitis lesions. We have to look at the nail beds, small splinter shaped infarcts, and also we have to look at the joint motions and effusions. Also we have to look for the eye, or check the eye, and we have to see the conjunctival petechia, we have to see conjunctivitis, punctate corneal lesions or uveitis or optic nerve changes, and retinal or choroidal abnormalities. Also we have to look, we have to palpate the lymph nodes, and then we have to look for after the consistency, size, and tenderness, and so on. And then we have to auscultate the heart, and we have to look after cardiac murmurs, pericardial raps, and so on. And also we have to palpate and the abdomen, and look for new masses or localized tenderness, and also sign of hepatosplenomegaly, and so on. So also we have a basic diagnosis test where we can do a CBC test, complete blood count, or we have to look for HIV ABAG test, which is antibody antigen test. We have to look for the liver function test, and then we have to look for a lot of other tests, such as the antinuclear antibodies, rheumatoid factors, C-reactive protein, ACR, and so on, as you can see here. For example, in case of bacterial endocarditis, as we saw before, we have to make 3 sets of blood to make sure that this is like a bacterial infection. Also, we have to look for the amount of the protein in doing serum protein electrophoresis, and we have to look also for tuberculin skin tests of interferon gear release assay, and we have to look for lymph nodes biopsy, and also we have to see the chest and abdominal CT scan. And yeah, and then we have the last one, which is the subsequent diagnostic approach, and this is actually physicians do by doing different microbiological methods, and also they use invasive diagnostic procedures and high-yield imaging studies. Okay, so the treatment for the fever of unknown origin. So once we make sure that this is a true fever, of course we have to give antipyretics to relieve the symptoms, and also if we have, or to reduce the fever actually also. And if you have, the patient is also suffering of shivering or chills, then we have to give a paracetamol or ibuprofen. And antibiotics will be contraindicated or if the bacteria it's not really diagnosed or not being indicated. And also corticosteroids, we can use it in case an autoimmune disorders are being confirmed after a diagnosis. Thank you so much and have a good day.